very much, Rob. It's a real privilege to be out there again, and delighted to be back again. And see so many good friends. Really appreciate you all coming out. Rob actually he understates his role when he was at the house group as a fellow. I was enthralled as a resident, not only with neurotology that I was seeing it there, but Rob's enthusiasm was just infectious. And I still blame him today for my being a neurotologist. So thank you. So, you were gracious enough to give me a tour around today. It's just wonderful to see what's been built here at Stanford. And as the group that you have here, we love all the work you're doing, and it's great leadership. Congratulations on everything built. Well, thank you. So we'll talk a little bit, a brief update on what's going on with Eustachian tubes. To possibly condense it all down for 45 minutes, but hopefully give you a taste. And like Jennifer, come on, visit. And I think once you do that, you realize there's a lot that can be done and so much more that needs to be done. I think we have far more questions now than answers, but at least we're asking questions again. And that's what I think is really happening. So disclaimers, I am a consultant for the Clarent Corporation, which until recently used to be down the street here. They're down in Irvine now. I'm a consultant, I don't have any equity interest, so no commercial interest in this. And I'm a PI for a randomized controlled clinical trial that we're doing now to get the balloon diet device FDA approved as an FDA mandated study. I'm also working with the Otodyne company. This is Sujana's surfactant, nasal spray. We'll talk about the off-label use for sinuplasty balloons, which I put into the Eustachian tubes, since we don't have an FDA-approved device for that just now. So Rob's heard me say this before, but it's always hard to think of the ear as another accessory sinus, but in reality, it is in practical purposes. It's an air-filled space that is subject to all of the same diseases that we see in the other sinuses. So the more I think of it as a sinus, the more I become to understand some of the diseases that we deal with in the middle ear. Don't forget the special sensory function. The main difference with the middle ear and the other sinuses is this very long and dynamic ostium. That's the Eustachian tube. It actually has some functions like its own organ. And other than that, the mucosal pathology, same as we see in the nose and sinuses. Now, Charlie Bluestone characterized the functions of the Eustachian tube. Broke them down into its ventilatory function, the ability to clear fluids, and prevent reflux. And that could be nasopharyngeal pathogens, as well as our voice and breathing sounds. So those are the functions of the Eustachian tube, and this is a cadaver Eustachian tube, human, just longitudinally open. So here's the nasopharyngeal orifice here at the 0 mark. So that would be the torus. And this is the cartilaginous part. Here it funnels down and becomes narrowest here at the cartilaginous bony junction, about 24 millimeters up. You can remember 25. And then there's about 6 millimeters of this junction where it's at its narrowest, and then it expands into the bony portion. Here's the middle ear. So by the time you get past 34 millimeters, generally in women about 38, men about 40 millimeters, you're in the middle ear. So Eustachian tube length 38 to 40 millimeters. First 24 is the cartilaginous portion. Now, one of the biggest problems we've come to realize is that there has not been a universal definition for Eustachian tube dysfunction. So it's been a black box, and we've dumped a lot of things into that box called Eustachian tube dysfunction. So we're beginning to have a need now for being much more critical about what we're going to define as dysfunction for the purposes of surgical indications and reporting and research opportunities. So we held this consensus meeting in Amsterdam 2 years ago now, a year and a half ago, and Schilder led the group. And we decided to define dysfunction as the inadequate dilation to produce the functions that Charlie Bluestone defined. So it's inadequate ability to ventilate from reflexes. So what are the consequences of that? And that's where we met a lot of differences of opinion. So the consequences, we could all agree, were that if your eustachian tube is blocked, you're going to get negative middle ear pressure. We can measure that and see that with otoscopy. That's retracted tympanic membrane. You can see a B or C type tympanogram, and we can measure it. These patients can have difficulty with barrow challenges like flight, scuba, and tall buildings. So those things we decided to agree upon as a consensus. Where we could not agree was otitis media with effusion. There can be inflammatory reasons for having infusions and biofilms and other things. So it's not universally caused by a faulty eustachian tube. You can get middle ear inflammation that will block the eustachian tube. It doesn't have to start with the eustachian tube. Same thing for recurrent acute otitis media. Perhaps those are an overly patulous tube in the young child that's refluxing inflammatory products or pathogens or nasal or gastric contents that's causing inflammation. So this may or may not be eustachian tube. This certainly is. It's retracted. It's not adherent. This is not necessarily a eustachian tube problem. This probably started as a eustachian tube problem causing a retraction to begin with. And then once the mucosa becomes adherent to the middle ear structures, Dr. Jack has done a lot of writing on this very subject. Other biological factors probably take over at that point and take on their own separate processes, independent of what's going on with the eustachian tube. This particular patient has a type A tympanogram, an aerated, healthy anterior middle ear. So the eustachian tube function is now back to normal, in spite of this progressive retraction pocket that may even go on to become a osteotoma. If you put a tube in this ear, you are not going to change that process. We're not going to do a balloon dilation on that patient. So we've got to become more critical about what we call an active eustachian tube dysfunction. We'll go forward now. So one of the hard lessons to learn was that the eustachian tube dysfunction seems to mostly, dilatory dysfunction seems to mostly occur in the valve area, the cartilaginous portion of the eustachian tube, which is not the narrowest part. The bony cartilaginous isthmus, although narrow, is usually open. Even patients have an effusion, so we went from endoscopy. So we've been studying this valve region where the mucosal surfaces open and close, and trying to make studies of that. So here's the right eustachian tube, here's the torus, and we look at this bulge here that comprises the valve, closes it, and has to open on demand. And it opens basically with two muscle movements, the levator raising the palate and medializing the torus, holding it medially. And this is like a scaffold against which the tensor then fires. So the tensor is very inefficiently oriented in humans. Charlie Bluestone has some very elegant writings about this. Perhaps it's because our larynges descended in the process of developing speech. You give Botox to an ape, all the primates, Botox their levator, and they do not get a middle ear fusion. You do that in an adult, we do. So we need both the levator and the tensor to prevent that problem. So a critical issue is how to look at the eustachian tube. So I'm going to hold that for a second. We've all been trained to look with a 0-degree endoscope. And so this is a 0-degree rigid, or the fiber optic scopes we use, they're 0-degree. When you do that, you get a great view of the adenoid, and you get a great view of the torus. You don't see into the lumen, so you're missing all of the structure of the valve. With a 45-degree or an angled view, you look into the lumen. So it's just like looking into the larynx. You can't look at just an epiglottis and say, you've seen the larynx function. You've got to get lined up down the axis so you can see the vocal cords opening and closing, and carefully study what's going on inside. So that's a big change from the way we were trained. So and so this is typically what I do. My initial exam is with a fiber optic endoscope, and I put it into the nasopharynx. Here's the adenoid. This is on the left side. There was the septum over here, so this is the right eustachian to the torus here. I'm going to turn the scope 90 degrees. There's the right side of torus. So I'm looking across the septum in this particular case to get that angled view down the lumen. Now, it's sideways, so we'll just turn the camera. Now we've got a beautiful view down the lumen. This is what it should look like. we'll be able to watch it open and close. So that's critical to be able to see it. And sometimes you get a better view down the lumen from the ipsilateral side of the nose, sometimes you get it from across the opposite side. Whichever gives you the better view. Every patient's different. I spray the patients. I have them phonate K, K, K to just isolate the levator movements. And they use a series of swallows to get the normal opens. And then yawns are saying ah to get a maximum dilatory efforts. So just to remind you of the histological structure, this is from Schutnick's text, actually, Sandoz wrote for Pittsburgh. So this is the torus here. This is the left eustachian tooth. Here's the medial cartilaginous lamina, the lateral cartilaginous lamina. This is the lumen here. So the valve, that bulge that I showed you, is comprised of all these layers of this lateral lamina, mucosa, submucosa, the osmond's fat, the levator, and then there's a little bit of fascia, and then there's the big bulk of the pterygoid muscles, the medial pterygoid. Here's the floor. That's the levator muscle in the floor. Sits under the torus, so that when we swallow, the levator comes up, holds the torus medial, and there's the tensor against which it's going to fire. Look how it's lined up tangential to the eustachian tube. It's a very inefficient diaphragm. Also notice the carotid artery proximity. But as long as we're dealing with the cartilaginous eustachian tube, we're staying away from the carotid artery. So this is very important for the surgical anatomy, keeping that cartilage between you and the carotid artery. So we'll look at a normal here. So this is with a 0-degree endoscope. I don't see into the lumen. There's the torus. This is the left side. Here's a 45-degree scope. There's the torus. And now we can see into the lumen. So I'm going to slow this down just so you can see it in real detail. I don't do this usually in the office, but I do for difficult cases, just like you would do a stroke. So with a swallow here, watch in slow motion. Here comes the levator. It's going to pull the torus medially. And it's going to stay elevated, against which this bulge of the tensor is now going to disappear. So there goes the bulge. Now it's open. And they're going to relax relatively simultaneously. So here is the torus. Medial cartilaginous lamina. There's that bulge of the lumen. There's the lateral cartilaginous lamina, the mucosa, submucosa, osmond's fat, tensor muscle, all that pterygoid bulk not behind there. There's the adenoid. So what happens when you acutely block the eustachian tube? Like you see here, this is an acute respiratory infection. The patient's usually got normal here, but he's got a cold at the moment, a lot of mucus. The muscular function's good. This is the right side, there's the torus, but he cannot open his eustachian tube. So what's going to happen to his middle ear? This was an elegant study by Hans Pau and a group of German professors, along with an Israeli very well known for eustachian tube work. We got together on a conference table like this one Saturday morning. They became very famous for this study in Germany. Holding under their tongue so they wouldn't swallow or yawn for as long as they could take it. So they wouldn't pop the eustachian tube, and they got it to pentagram in the ear. So of course Professor Pau, the lead investigator and the chair, he held out the longest. And he finally gave up.
Without speaking.
He finally gave up at an hour, 2 hours. Couldn't take the pain anymore. So this is very interesting. We're not sure why it went positive a little bit initially. It could be some adjustments in the just getting used to the manometer in the ear. But you see, after that, it becomes very steady, fairly surprisingly rapid decrease due to the middle ear gas exchange that's going on at all times. Principally nitrogen is being absorbed over that period of time. Oxygen and carbon dioxide are absorbed within minutes, but the nitrogen is being absorbed here, and we're down to minus 100 here in just an hour. That's pretty significant already. That's to start dropping your hearing, and down to minus 170 by 2 hours. So, go out another day or two and have an fusion. This is a very real phenomenon. This is the first time it's been measured in humans. I want to call your attention to this work by Mike McDonald in Wisconsin, who's been doing seen an MRI and CT scan. He hasn't published the MRI yet, of eustachian tube function with swallows. And what he's been seeing, a couple of interesting points. First of all, he's been noticing these air boluses that seem to percolate up the eustachian tube, even after it's closed in the nasopharyngeal orifice. It could be an artifact of not being able to get enough frame capture, but it seems to be fairly reproduced across the patients. So it raises the question, we've always been thinking about the eustachian tube as something that's got to open up all at once, a full dilation. All of our eustachian tube function tests have been based on opening and closing pressures, sonotubometry, single sound goes all the way through. And yet none of the tests for eustachian tube function have been correlated with clinical function. We can't predict the success of the TAB test based on any eustachian tube test. Maybe this is part of the reason why. Maybe there are other mechanisms for air percolating up, even after it's closed distally, so that air is progressively working its way up over some time into the middle ear. None of the tests that we've developed to date would account for that, and that could explain some of the other findings that we're seeing with some physiology that we don't have the time to go into. The other thing, this is the group of the pterygrade muscles, the medial and lateral pterygoids. They run right along the tensor belli palatine. And what he's seeing is that there are synchronous movements with the pterygoid muscles when we do our swallows and yawns. So are the pterygoids acting as accessory eustachian tube dilated muscles? Do we share trigeminal innervation? We don't know. So it's raising more questions than answers, but it's really a compelling thought.
We have patients with motor 5 dysfunction, complete trigeminal dysfunction and atrophy of the pterygoids and masseter. I've never noticed, but that's an interesting group to look at.
Yeah, exactly. We'll have to start critically looking at that. Are there more prone to eustachian tube dysfunction? Maybe not, but there may be other relations that are important, and I'll come to that. This is some work done in Pittsburgh where this is Juna Alper, who did a very elegant study. I went down to visit him to see him do this. Not many patients, normal subjects, can put up with this. So he's got an endoscope in the nose, he's got hook wire electrodes in the levator and tensor muscles, and he's doing sonotubometry all at once. And basically what he's showing is with this swallow, the first thing that you see is levator function, followed by tensor function, followed by opening of the valve with the sono. It's a very elegant verification of what we've been observing endoscopically. So it's quite reassuring that the physiology is giving some credibility to what we can observe clinically in the office. In other words, you can learn a lot from a careful endoscopic exam. Learn a lot about the physiology of what's going on with these stations. So a couple of examples of pathology. This is the right side. So this is the torus here. There's the adenoid, moderately hypertrophy. But look at this swollen, wet torus. How it becomes thrusted anteriorly as the patient swallows. So she has a lot of allergic disease, and it's slamming the door shut of this eustachian to the point where it's supposed to be opening. So it's a combination of being squeezed by the adenoid and by the pharyngeal constrictors with the swallows, and also the bulk of this posterior cushion, all coming together to cause this anterior thrusting, which is very common. We see this in a lot of the inflammatory conditions. Not everybody has it, but it's one of the things you can really look for. And we do know that adenoidectomy is more beneficial in patients who have contact between the adenoid and the torus. This could be part of the reason why. So it's something we've been really looking carefully at. This is another allergic rhinitis patient, again, right side. I want to call to your attention, look at all of this bulbous edema, thick post-torus virus, and yet inside the lumen here, there are patches of atrophy. That yellow is the Ostman's fat showing through the very thin mucosa and submucosa. So with chronic allergic disease, you can have this contradiction of a lot of disease, perhaps on the nasopharyngeal side, but as you get into the lumen, you actually see atrophy occurring. And that's important because some of these patients actually turn out to become patulous down the line. And we miss it because we've been treating them for years, if not decades, for dilatory dysfunction and really to open. I'll show you an example of that later. So it's something you really need to be careful about. And here's that case. So this 62-year-old male, persistent miliary effusions, virtually all of his life, allergic rhinitis. He had a lot of acute otitis media as a child, antibiotics with no tubes. And then 10 years ago, he starts needing tubes. What just changed 10 years ago? He had a cold, and he had a bilateral effusion. And after that, just never went away. Effusions broken only by the tubes. He had 5 sets of tubes. Allergy tests negative with sniffing a lot. This is right here. Two bubbles. CT was essentially normal, other than effusion. Left TM perforation, so that is doing really well. So what's going on here? Traction. So what is going on, the key is sniffing treatment. Now, patients with this kind of effusion sniff. And I observed him sniffing fairly forcefully. And yet his nose was relatively clear, so why is he doing that? You've got a patulous eustachian tube, and he sniffs this firmly to try and close down his valve because it's more tolerable to him to have conductive hearing loss and that kind of retracted ear than it is to have the autotophony of the voice and breathing sounds. So he didn't come in complaining about autotophony, but when I asked him, why are you sniffing like that? My ear's all blocked up, I just can't stand how it sounds. So I looked at his ear to see what he's doing, and sure enough, he gets a little air in there, he hates it, sniffs it right in so he doesn't get that. If you look at his eustachian tube, it's patulous. So patulous in the textbooks is listed as a rare phenomenon. I will put to you that it is far from rare. It's actually very common. We just miss it all the time. So I've got other examples if I have time to show you. Tickle sclerosis, retraction pockets, for patulous eustachian tubes. We miss it all the time. I want to show you here is a right side in a 12-year-old. She's got a miliary effusion. This is her torus, and she's got an amyloid hypertrophy and a significant anterior thrusting. That's her lumen right there. I apologize about the quality, but kids, I usually use a pediatric endoscope. So watch that anterior thrusting. It contacts the adenoid, pushes it forward, slamming the door on the eustachian tube when it's supposed to be open. Now, contrast that to this patient over here, a 15-year-old with equally significant adenoid hypertrophy. Here's her torus, and yet she's got a lumen here, and you don't see the anterior thrusting. What's the difference? She's got this gouged out area here in her adenoid, although it's hypertrophy, it's protruding significantly. It's not making the same contact with the torus. So she does not have the anterior thrusting. Got a very significant, probably equal volume of adenoid disease. And this is in part probably why the studies have shown that looking at adenoid volume doesn't correlate with miliary effusions or with benefit from adenoid activity. It's about adenoid in contact with the torus. That seems to be what's important. So we've seen inflammatory conditions being the most common association with dilatory dysfunction we've seen, observed. So in this early series that we did, we looked at the causes for dilatory dysfunction. 92% of them were some kind of a functional obstruction problem, and almost all of it were mucosal inflammation. So what's causing it? It seems to correlate with all the usual suspects: allergic rhinitis, rhinosinusitis, adenoid disease, reflux. You can get a smattering of other more rare things, samples, triad. Adenoid hypertrophy, compressing eustachian tube. Well, you have seen some examples of that. You know how to treat that, but very few patients actually have a cartilage problem, and it's quite rare to have an anatomical complete blockage or obstruction like an EA process. 8% of our series actually had just a muscular problem, so inadequate function of one or the other muscles, or lack of coordination between the two. I don't have time to show you examples of this, like a leaf relaxing too early before the tensors have a chance to find. These things do happen. A patulous eustachian tube, I'll show you that later if we have time. That's a concave defect in the length of the valve, so you can see the defect, and it's usually in the anterolateral wall of that bulge of the valve. That convexity becomes a concavity. So you can see that. So I'll show that to you. This is to remind us about inflammation draining from the nose. So this is pneumonia, sinusitis, middle ear effusion. Here's the pus draining anti-gravity around the eustachian tube orifice because of the mucociliary flow, and then it's going into the pharynx. It's a target organ for the disease. So we're seeing a lot of inflammatory disease associated with eustachian tube dietary dysfunction. So the question is, well, where is this inflammation coming from? We started to try to critically study that. Now we're all familiar with Waldear's ring, adenoid. This is the left torus. This is the tubal tonsillar Gerlach, so you're familiar with that. We started doing some biopsies, and as you'd expect, this looks like adenoid tissue, lymphoid follicles. And yet what we found was that as we go deeper into the eustachian tube, we can have lymphoid follicles actually penetrating quite deep into the eustachian tube. Much, much deeper than I had appreciated, and I haven't seen that in textbooks. So this cobblestone that you see, those are lymphoid follicles, and they can penetrate fairly deep into the lumen. So we have adenoid disease penetrating into the lumen. That may have something to do with the inflammatory disease. Now, take a second and just talk about how we approach the patient with ear fullness, oral fullness. This is the main complaint that they walk into the clinic, right? This is an algorithm that we developed and refined a bit. We refined it a bit with that consensus meeting. So the patient with ear blockage, if they've got a retracted tympanic membrane, that's much more straightforward. You can measure or see effects of negative pressure, measure a type C or B tympanogram, do a merrygotomy or see what they get. So that's eustachian tube dietary dysfunction. So that's straightforward. Where it becomes more difficult is the patient's walking with a blocked ear and they've got a normal tympanic membrane. Now if they've got a clear history of barrel challenges, scuba, get to the bottom of the pool. That's most likely a dietary dysfunction that's less severe. The issue is when they don't have those kind of complaints, you have to think about the patulous eustachian tube. You can pick that up by catching them while they're symptomatic. If they're not symptomatic at the moment, I have to go and run them down the stairs for a few minutes, and they'll usually will get symptomatic. And then you can watch their eardrum move as they breathe in and out. So we do ipsilateral nasal breathing. Just block the other side. Look in the ear. And they're breathing in kind of the way you, as if, no more forcefully than as if you were listening to the lungs. If you breathe in too deep, too hard, and fast, anybody with normal eustachian tube function will suck in their eardrum and blow it out. So just in and out as if you were listening to the lungs. And you can usually see the eardrum move. Or you can do a tympanogram and measure that movement. It's even more sensitive. So you have to think about the patulous eustachian tube. And they usually, not always, sometimes people with bad disorders, they usually have autophagy. So what if they don't have autophagy? The eardrum's not moving. The tymphanogram's negative. What do they have? Well, most of them break down into one of these things. The majority are temporal mandibular disorders. And we find that by palpating their musculature, finding that they've got spasms or you have to think about Lloyd Minor syndrome of semi-syphilic They can have autophagy. Usually have their voice, not the breathing. The breathing is not bone conducting sound. So this is a significant cause for autophony, ear fullness, and interestingly, their symptoms get better when they put their head down. We'll talk about that more if we have time. So we spend a lot of time diagnosing TMJ in our clinic, in our eustachian tube clinic. Maybe 50%, 60% of the patients I see may turn out to have a TM disorder rather than a eustachian tube problem. Also think about inner ear high drops, but that has much more of a characteristic fluctuating component. So you can usually pick that up on this. From Jannike's book, just to look at the cross-sectional anatomy. So here's the left torus right there. This is the lumen. There's the lateral cartilaginous lamina. Here's the tensor belli palatini muscle. Here's the medial pterygoid muscle. They really share a wall there. So they probably are connected in terms of pain. They've got some motor relationships, the sense of the trigeminal nerve. So there's probably a lot more going on in the relationship with the temporal, with the muscles of mastication than we previously appreciated. And I think that these big muscles of mastication give us a lot of the pain and pressure sensations that we're bringing down the ear eustachians. The patient's got a normal ear, a normal contact membrane, normal pressure. You put a tube in, they hate it, it doesn't help. So think about those. The way I examine for that now is I do this bimanual exam. First I'll examine the joint, have it open up, and feel into the depths of the glenoid fossa, look for tenderness, crackles. You will not do that. I can move, translate from one side to the other. Most of the problems aren't the joint, and it's not bursitis. It's much more commonly in muscles of mastication. So we can palpate with a bimanual exam, one finger running up the ramus, and then that finger, my index finger, then follows the undersurface of the zygomatic arch. So you're feeling the insertions of the masseter muscle there. Feeling for cord spasms, tender spots, hypertrophy. And then you go medial to the coronoid, medial to the ramus. So first, I'm lateral to the ramus. Now I'm going to go medial to the ramus into the pterygoid fossa. That's where the insertions of the lateral pterygoid and the temporalis muscles onto the coronoid process. So you can get up there a little way, and you'll feel it's foggy. You feel hypertrophy. They're frequently starting to jump out of the chair before you begin to press. This is something you can practice on yourself, because if you push too hard, you'll generate pain in anybody. So if you practice on yourself to learn what's the correct amount of pressure, when you do that on the patient, you'll very quickly be able to differentiate between normal and abnormal. So we do a lot of that, and try to set them up with our oral medicine colleagues who really manage that. Okay, so a lot of inflammation at hand, and it turns out they're all the usual suspects. You know how to treat all those things, you know how to do adenoidectomy and all the medical things you need to do. So you treat those things, and not surprisingly, a lot of eustachian dietary dysfunction problems can get better. So the majority of the folks getting sent to us actually don't wind up operating. But if they failed medical treatment, you think you've done due diligence, they typically tried a tube or more. Most of our patients have many tubes. It works, then the tube comes out, the problems come back. These are the people we're selecting for surgery. Perhaps they have irreversibly injured mucosa. Not sure, maybe they have biofilms. We don't know. There's lots of hypotheses. But this group of persistent mucosal disease that's causing persistent ear problems, these are the people we're selecting as indications for ear surgery. So, miliary fusion, non-adherent atelectasis. So this is not bound down, starred down, because if we're worried, an operating on stage 2 won't help the patient clinically. So these are non-adherent atelectasis. They've got abnormal companograms. They're symptomatic. They get better with a tube. Or they may have a normal ear in the clinic, but they have flight or scuba barrel challenges. So those are our patients. We did this in the lab initially with these sinuplasty balloons, finding that they could fit into the eustachian tube quite well. This is cadaver right there. And it lodges into the mid-portion of the cartilage in this eustachian tube, which tends to hold it in reasonably well. And it dilates that middle portion very well in the cadavers. So we took that to humans. And so this is the left side. Here's the torus right there. This is the adenoid. So this is a sinuplasty balloon with a 70-degree frontal sinus guide catheter. It's a 45-degree endoscope. There's the inferior turbinate. I'm going to follow that along. And after you pass the turbinate, there's the anterior pillar, or anterior cushion, the torus, or posterior cushion. Now, our natural tendency is to aim toward the ear, but you can't do that. You've got to get around the posterior cushion, the torus. So you notice that course correction. I'm aiming more medially than you would have thought to get this to slide in there nice and smoothly. That little yellow mark should lie right abeam this anterior call it a cushion. It's 31 millimeters from the tip, so it should not go into the lumen. I'm blowing up the balloon now to 12 atmospheres, 2 minutes. Do it just once normally. Deflate, you saw that mucus come out. And you'll frequently see a little trickle of blood like this as you get some mucosal tears. You don't think these mucosal tears are significant. I've never had to do anything about that trickle of blood. It's very self-limited. Then mucosal tear in the vascular literature, we know that endothelial tears actually heal in the scar and help with the final increase in lumen diameter. We don't know that here in the station tube. This is our most recent study. So I went to Finland to do a research sabbatical, and I started doing this clinical trial in Finland with Silvola. So these are his patients that you're seeing here. And after I left, I came back a couple of times, helping with some more cases. But this is his series, 80 consecutive cases. 42 of these selected out for just tubes, Eustachian tubes, the balloons alone, no other adjunctive procedures. Almost all adults or a couple of teenagers. So very strict indications, more than 5 years of almost all of them hepatitis B is a fusion broken only by a tube. Tube comes out, symptoms are immediately back. One of the patients had just atelectasis, they all had previous tubes. We created the mucosal inflammation on a scale of 1 to 4. This has just recently been validated and published now. Our follow-up, minimum about 1.5 years for this study, 4.5 years max, 2.5 years mean. So reasonable midterm follow-up, not long-term follow-up. So this is what we found. Nobody could do a Valsalva before. 92% of them could do a Valsalva afterwards. Dropped down to 80% by 6 months. But that then endured. Pentagrams. 1A, breast C's, B's, or they were open to a tube or a perf. Afterwards, a lot of normals, A's, C's, no B's at that point, still some open. Jury's out. Interestingly, these mucosal inflammation scores, normal, more mild, mostly mild, moderate, severe. Afterwards, mostly normal, mild, moderate, few severe. I was blowing up the balloon for 2 minutes. Affected mucosal scores years later. We were surprised by that. This is what it looks like clinically. So here's a left side, here's the torus, here's the lumen. It's kind of bulbous, edematous mucosa, thick, wet. Don't see too far into the lumen, even when they dilate. There's bulbous tissue here. Afterwards, much drier mucosa. You can see the vessels much more clearly. You can see a little bit deeper into the lumen. You can appreciate that more here. You don't see that edematous border. You can see previously. A little bit deeper depth of penetration. You don't have that edema along the anterolateral wall. The floor is much healthier. How could this be happening? Well, really puzzled by that. So, started doing some biopsies before and after the dilation, and this is what we found. Lymphoid follicles, as you'd expect, and disorderly array of the pseudocolumnar epithelium, lymphocytic infiltrate penetrated through the epithelium here, loss of cilia there, a lot of lymphocytic infiltrate into the submucosa. Immediately after the dilation, what we're seeing here is a very interesting excoriation, stripping of the mucosa right off the surface, right down to the basal layer. And it's leaving the basal layer intact, which explains why you don't really appreciate that clinically. This just does not look that exfoliated. And it probably explains why they heal so quickly as opposed to like the lasers that we've done. So, just below that, even more interestingly, these follicles are just squashed. They're flat. Lymphocytes are flat. And yet, immediately below the submucosa, you see the submucosal glands are this. So the effect of this seems to be very superficial, stripping off the surface mucosa, sparing the basal layer, crushing the lymphocytic infiltrate. What happens a few weeks later? We have 3 of these that we published. I've got 5 of these now. They're all showing the same thing. Pre-op, tense infiltrate, loss of cilia, and disorderly epithelium. Post-op, they have normal, healthy pseudocolumnar epithelium, cilia. The lymphoid follicles are gone. A little bit of lymphocytic infiltrate, but some thin scars replacing most of where those follicles were. So this reminded me, this is basically what you do with an adenoidectomy. So that's changed how I'm thinking about this. I think what we're treating with the Eustachian tube now is inflammatory disease, penetrates deeper into the lumen than we previously realized. It's just more adenoid disease, Waldeyr's ring. And we just happen to stumble on a technique for getting into the Eustachian tube deep enough to treat this. And it's very interesting with this balloon, happens to have some very interesting superficial effects that strip off perhaps irreversibly diseased mucosa. If there's biofilm there, maybe it's going. It's allowing regeneration of the epithelium, it's preserving the basal layer, and it's squashing the lymphocytic infiltrate and allowing it to heal with scar. So there are permanent effects that can be happening here. It's just what you'd see if you did a biopsy after adenoidectomy. So I think we just found a way of getting your adenoidectomy deeper in there. Briefly, out of time, similar results in other series. This is McCool and Vijay Anand using a symptom score that they developed and showing that their early results, pre-op, 6-month results dropped to improved 3.3, so that's a significant improvement in the symptom scores in their patients. And that's holding out to 18 to 36 months. So the results aren't enduring. This is not a procedure that I do repeatedly. I have rarely done that. Similar results in overseas. So the majority of these procedures have been done in Germany, where the procedures are approved with approved devices and reimbursed quite well by the government. This is Holgar Sudhoff's group. 1,000 Eustachian tubes, 600 patients, and typically pretty good results, 71 to 82% results. Now they've got similar problems in follow-up that we do here in the States. As you see, as time going on, their ability to get the patients back to follow-up is not good. So that raises some questions about the validity of these. And people are using different scores and different means for assessing improvements. That's a problem. This group, Tisch and Meyer at the military hospital in Germany, 200 children, pediatric cases with glue ears, not recurrent acute otitis media, that may have a problem with reflux. We don't want to open them up to reflux and have more pathogens getting up there. So they didn't select those patients, the ones with glue. 70 to 85% significantly improved without a tube. So stay tuned, that's very interesting. Another group looking at pediatric cases, 64% improved, not quite as good. They tried to use their tubal manometry. It's a device we don't have here. That's what Sudhoff uses in their group for assessments. Could not correlate their success or failure with the tubal manometry results. They had a failure of the device, a failure of being able to train the kids to do it. Again, there's no gold standard tube test. I'm going to our post-op instructions, the most important thing we tell them is not to blow the nose for the first week, because it would be mucosal tears. After that, I do have them start a modified Valsalva. So it's not a pure Valsalva, which could be more risky. But they hold the nose closed, start raising the pressure with a gentle nose blow, and then swallow hardly using muscles at that point. Very important to keep the underlying medical problem under control, because if you don't, adenoids can go back. These are the complications that have been seen. If you don't use atraumatic technique, you can get big lacerations, false passages. If you get a false passage and you've got your patient blows their nose, you can get there on the case from overseas. Hair went all the way down to the medial side. There's no consequence of this. It's just very scary for the patient and the people involved. If you use a guide wire to get your Eustachian tube catheter, guide catheter in, You have to remember to remove it so you don't overpressurize the head of the ear. You could get hearing loss if you did that or tinnitus. But no reports of an infection, scarring, making people worse. And to my knowledge, I've not heard any confirmed cases of use of a carotid injury. So I'm just going to mention a systematic review of balloon dilation. There have been a few of these recently, and our study's been a couple of these. So I'm guilty of this as everybody else. The study's been criticized for their poor quality, high risk of bias. These are retrospective studies, which they have to be for a pilot study initially, just to see is this worth doing a prospective study. So I think we're through that phase, and most people are getting somewhere in this 50 to 97% range. I think most people get 70 to 85% in their retrospective series. The real problems with widely varying inclusion criteria, hopefully we're going to fix that by defining Eustachian dysfunction. And we're trying to, for the same reasons, have outcome measures that will be more uniform. So we clearly need for randomized controlled trials. We're in the midst of one right now of a balloon against nasal steroid sprays. We're doing that as an FDA mandated study. It's a 22-center study that's possibly accrued enough patients. We're on hold right now and data analysis. So stay tuned on that. There's also a study going on in France, but it's not controlled. We are doing a prospective study of balloon dilation. So controlled studies, prospective studies are coming out. So what I want to leave you with is some thoughts about Eustachian dietary dysfunction. Think about inflammation, all the usual suspects. Treat the rest of these things in your practices. If you're going to go do surgery, do the things you would normally do. If they have nasal disease, you fix that. Nose, sinuses, turbinates, adenoid. If you think you need to go into the Eustachian tube, now you've got the tools you can get there. Could be a laser, could be a microneedle reader. I think the balloon works better because it's concentric all the way around, circumferential, and they seem to heal very quickly, and it seems to be very effective, at least as far as it's concerned. So to truly be effective, it's got to prove its point on a randomized controlled trial. Yeah. Just going to leave you with one last thought here. You may have heard the last couple of weeks, clinical guidelines came out. I was privileged to be able to participate on this. Clinical guidelines for otitis media diffusion. This was not a joke. But I put it up here in case for a good one. This is supposed to be useful to help our primary care doctors understand how we as otolaryngologists have to work through all of this. So this guideline was done with a broad spectrum of stakeholders, including patient advocates, primary care docs, family practitioners, etc. So all these people at the table, Rich Rosenfeld, tremendous credit to how he runs these panels. It's an unbelievable wealth of knowledge. He really understands how to do these things. We've made our specialty a model for how to do these clinical guidelines. So it's really an honor to work with him on that. So just to give you a snapshot of what's new and important on that, strong recommendation for the pneumatocostomy in making the diagnosis of miliary effusion because it's frequently misdiagnosed. And pneumatocostomy, we know how to do it, whether pediatrician and general practitioner colleagues often miss that. Tympanometry and audiometry are a backup to the pneumatocostomy. In the normal child, if the effusion persists beyond the 3-month recommended watchful waiting period, good idea to get those things and start making a decision about the operating time. Prior to that, you don't really need to do that. In fact, you don't necessarily need to do the audiometry or the tympanometry as part of the guideline. It doesn't necessarily make a difference if you do that before. Now, the difference is the at-risk child, so syndromic or learning disabled or some other at-risk child. Not apply. You want to get them identified, worked out, audiograms, plugged in, early intervention as quickly as possible. This was the other, another big change. Medications. Previously, they didn't take a strong stance. It's now a strong recommendation against all of these players. Oral steroids, possible benefit, it's short-lived, maybe a week or two. Nasal topical steroids, no known benefit. The Mayo study 2011 showed no benefit for treating eustachian tooth dysfunction. Now, problems with that, not necessarily clearly defined. Second issue, nasal steroids do work against allergic rhinitis. So keep that in mind. Use it to treat the allergic rhinitis. If you've got a garden variety biliary effusion in children, I'm no longer recommending a nasal steroid spray. And this is a very difficult pill for people to swallow. But it's based on the evidence, and there's this very significant lack of evidence. Same thing for treating antibiotics. So I used to get another round of antibiotics right before thinking, are we going to do a tube or not? I guess I'm going to stop. Antihistamines, decongestants, same thing. In fact, decongestants may drive the mucosa and make it worse. The last important point, adenoidectomy, it actually only benefits for otitis media effusion if you're 4 or older. The evidence was not there for under 4. So if you want to do it in the under 4, there should be another reason. Obstructive sleep apnea or other issues. But again, if it's purely because of an effusion, greater than equal to 4 is what the literature is clearly showing. After that, adenoidectomy works just as good as a tube. There's case studies that still holds up well in these studies. So with that, if you want to hear more about this stuff, we put on this annual course in Boston. Next one's in April, 4 through 6. Love to have you out there, definitely out there. Hopefully you had a good time. So again, it's a real privilege to be here. It's a great privilege. It's a joy to talk to you all. Thank you very much.
Bravo.